and welcome to the first episode of Medicine Uncorked. I'm Michael Ipock, a nurse practitioner and owner of Wiregrass Direct Primary Care, a family practice treating all ages that started in 2019 just before COVID. My team and I currently care for over 7,000 patients in the greater Tampa area of Wesley Chapel, Florida. As one of the rare independent primary care offices, I have struggled as a business to survive, and it's time that I pull back that curtain and reveal the true business of healthcare, the part that no one talks about, not with patients, not the schools, not even in the exam room for students. So let's pour a glass of wine or coffee if you're into that, and let's uncork the truth. I'm going to be opening a bottle each week on our podcast for us to enjoy sipping while we talk about the industry. Because the more I talk about it, the more fired up I get, and the more wine I'm going to need. My favorite wine is red wine, and studies show that the flavonoids and phenols in red wine have antioxidant and anti-inflammatory properties that could possibly lower the risk of coronary heart disease. And I'm not saying go out there and get lit, but just saying in moderation, a little red wine may have its benefits for you. So it only makes sense for the occasion to start this podcast series with one of my favorite wines, and it's the Red Schooner from Wagner family in Napa Valley. The cool thing about this wine is it comes from Malbec grapes. They come from the Andes mountains of Argentina, and they chill them and then transport them up to the Napa Valley via ocean on a voyage to Camus. And that's where the bottle gets its name, Voyage. And they don't put the year on the bottle. This one's a Voyage 12, and it's from the 2022 vintage, so that makes it a little bit non-traditional. That's what I'm looking for. So let's talk honesty. Most of us went into medicine to help people. We love the science, we love the connection, and we love making a difference. But the hard truth, you can't help anyone if you can't pay your rent. Healthcare is a business, whether you're a doctor, nurse practitioner, physician assistant, therapist, medical assistant, or receptionist. And if you're helping patients, then you're part of a system that runs on money. Let's face it, most of you wouldn't be there if it wasn't for the money. If you weren't getting paid, we wouldn't show up to work. And we don't just get paid to sit around and care for patients. We get paid per code, per service that we perform. So if you're not documenting right, coding it right, and running a business right, you're losing money every day. And that's the system that we inherited. That's the system that we are charged with understanding if we're going to be successful as a business owner. There are two dominant models in healthcare. One is the fee-for-service model, or FFS for short, and the other one is per member, per month, or PMPM. The FFS model pays you only when you do something. So you do something, in return you get paid a fee. The PMPM gives you a set monthly fee per patient, whether they come in and are seen or not. So every month you're going to get a payment, even if you don't see the patients. They each have their pros and cons, but either way, you're running a business, and that must make the numbers work. So 90% of private practices run on the PMPM model if they accept insurances. So I want to go ahead and clarify, this series, while it might have some good information for cash offices, We're focusing on the mainstream healthcare system that involves insurance and actually using the correct diagnosis or ICD-10 codes. We'll get into the cash side of healthcare at a later date. Okay, where was I? Yes. 90% of private practices run on the PMPM model. And I'm guessing 80 to 90% of these practices are physician ran or owned. Why? Because insurance companies will not contract with nurse practitioners. And this goes back to CMS rules regarding attribution. This is a key term that everyone should know and understand. What I'm going to do is I'm going to go ahead and read from the 2015 fact sheet that was published by the Center for Medicare and Medicaid Services. And this was August of 2015. So there's 2 steps to being attributed a patient under the rules of Centers for Medicare and Medicaid Services. So step 1, a beneficiary or patient is attributed to a TIN, that's the tax ID or tax identification number or employer identification number. So TIN and EIN are synonymous, but that's like a social security number for a business. Again, the patient is attributed to the TIN if the TIN's primary care physician, PCP, defined as family practice, internal medicine, geriatric medicine, or general practice physicians, keyword physicians, accounted for a large share of the allowed charges for primary care services for the beneficiary than PCPs of any other TIN. So basically an internal medicine doc in any business, because every specialist is an internal medicine provider, so they all have probably an internal medicine, most have an internal medicine taxonomy ID, and so they could still possibly get attributed a patient if they weren't seen by the primary care physician. And it says primary care services include evaluation and management services included in the office and non-inpatient, non-emergency room settings. So that's step 1. And there's a few more sentences in there, but it's unrelated. So step 2 is the second way that a patient can be attributed. So it says beneficiaries or patients who are not assigned to a tax ID after the step 1. So for whatever reason, they're unassigned. But they may be assigned to a tax ID who step 2 professional, physician specialist, nurse practitioner, physician assistant, clinical nurse specialist, their services accounted for more Medicare allowed charges for primary care services than any other tax ID. Here's the key. However, in order to be attributed to a TIN in the second step, a physician at the tax ID, regardless of specialty, must have provided primary care service to the patient during that service year. So if they do not receive care from a MD or DO within the tax ID, if it was just a nurse practitioner the full year, that tax ID will not get attributed to patient. Not in step 1 and not in step 2. Okay, so just so that we're clear on that and we have a full understanding of that, nurse practitioners cannot be attributed patients yet, according to the CMS standards. And that brings us to the next thing. That's why most PMPM models are also not given to private practices. They're given to larger health systems, like organizations, like the Accountable Care Organizations or ACOs, Managed Service Organizations or MSOs, and Clinically Integrated Networks or CINs. These systems spread the cost utilization and savings across the system that contains several offices who all receive PMPM. And since NPs by themselves cannot be attributed patients, according to those standards that I just read, then these organizations usually do not allow an NP to join because as a whole, they will not get credit for attribution for anything that nurse practitioner does for those patients. Okay, so now back to the hard truths. This means that as NPs, we are stuck with only doing the fee-for-service model. If we can find an insurance rep in the region that'll work with you to allow you to contract, 90% of the time though, you're just going to get the rejection letters that give you some generic reply that they're not contracting within the specialty at this time and tell you to reapply for a year after a year. They won't let you reapply for a year. So this brings us to the eat what you kill model, which is similar to attorneys, mechanics, and other professionals that are paid per service they provide. You see, the American Medical Association, or AMA, does not pay your salary. Hospitals do not pay your salary. Insurance companies do not pay your salary. You need to accept, as a provider, you pay your salary, and it's based on what you produce. And yes, that money either comes from the patient, the government, or private insurance companies. And that's where the phrase comes from, eat what you kill. It's brutal, but it's real. You bring in the patient, you build a CPT code, and based on how well you document, code, and your contracts, you either get paid fairly or not at all. In my experience, this has been a really hard concept for nurse practitioners to accept, and even some doctors. Most are used to getting paid an hourly wage or salary and demand this inflated salary because they add initials to their name, yet know nothing about billing and coding and actually bringing in the money. And as you gathered, this is a really important aspect of the business. Can you imagine the car mechanic charging 1 hour for a complete engine rebuild that took 10 hours? Or an attorney only charging for the 20-minute court appearance with no billable hours preparing the case and reviewing records with the paralegal? These concepts are not new in business and should be taught during school. I mean, if you're going to come out of school asking for 6 figures, shouldn't you be able to produce at least that in revenue for the practice where you work, or for yourself if you so dare to open your own practice, just as I have? This is especially important for NPs and physician assistants who may be doing the exact same work as a physician, but getting, on average, only 60% or even lower 40% of the reimbursements of a physician. You need to know how to bill, period. And we aren't even going to touch on how prepared for practice NPs and PAs are right now. I know that has a lot to do with the industry, and it, even if the person graduates with a master's degree or doctorate degree, what other industry do we still have to train for months on how to do the job? Well, we'll talk about that some other time. So let's talk about the patient. Oh yes, the patient. God bless you all. Ever since the Affordable Care Act, deductibles have gone through the roof, and most people, especially those who purchase from the healthcare.gov website, or marketplace as they call it, will have higher deductibles, which is the amount a patient has to pay out of pocket before the insurance pays anything. Then after meeting that deductible, the patient will have co-insurance, for example, a 75-25, where the insurance pays 75% and the patient pays 25%, or a flat like $35 copay. So they'll still be paying out of pocket until they meet the out-of-pocket maximum, or OOPM. And patients think just because they pay hundreds of dollars a month in premiums that they get free healthcare with no out-of-pocket cost. This creates confusion, and a lot of times, for instance, my front staff, they get yelled at daily and cussed out over $10 or $20. It's ridiculous. And this might be the only money we receive. We might not receive anything from the insurance. I mean, right now my office has over $250,000 in collections that I will never see because the front desk just gets tired of arguing with people and allows people to be seen. One more hard truth for thought. Our average per patient in total revenue is $42.65 as of July 17th, 2025. That's not profit, folks. That's revenue before expenses per patient. And most patients are only seen about 4 times a year. That means every 90 days we see a patient, we collect $42, which comes out to about $170 per patient per year. How is that? How many businesses out there could do the same thing? Can I pay my lawn care company $175 to take care of my lawn for the year? How about the pool company? How about my house cleaner? Why is it that medical treatment of patients is valued so low, and why do we still get cussed out for that? It just doesn't make sense. All right, we'll move on. So how about fixed costs? Fixed costs are coming for you. Let's say you start a clinic. Congrats, you're now the CEO. And the first question you should be asking yourself is, how much does it cost to keep the lights on? For this example, we'll use rent at $3,000 a month, which is average for about a 1,250 square foot office and where we're at. The EHR system, electronic health records, we're talking probably $400 a month minimum, and that's per provider. Medical supplies, you're going to spend about $1,200 a month. You have phones, internet, insurance, credentialing, subscriptions, forms, gloves, pens, coffee for patients, you name it. Even if you have 0 patients, these are bills that are still coming due every single month. So here's the magic number that you need to find. Monthly overhead divided by hours you're open equals your hourly burn rate. Most businesses are open 40 hours a week, 4 weeks a month, so that's 160 hours. How much money do you have to make every single hour just to break even? You see, whether you like it or not, if you're billing insurance, if you're ordering labs, if you're delivering services, you're a business owner. You're in sales. You're in operations. You're in compliance. You may not have asked for this role. You may not have been taught this during your studies. You may not be aware of this as a patient. But if we all don't accept this, the providers are going to get burned out, go broke, or both. That's why this podcast and this course exists. Because we all need to know the business side of medicine as well as the clinical side. This isn't just about private practice. Even employed providers are being measured on productivity, coding accuracy, and contract value. You cannot ignore the economics. So what's the goal this first week? I hope that you tune in every week to listen to these updates. But first and foremost, accept the mindset shift of being a business person. Secondly, if you're a provider, list your actual costs. We're looking for per hour costs. Thirdly, understand that how you bill determines how you get paid. And most importantly, stay engaged, because we've got 7 more weeks of straight up healthcare truth. Next week, we're digging into the real cost of running a medical office, and I mean everything down to toilet paper and toner. So if you're a student provider, a new NP, or someone thinking of opening your own place, this is the episode that might save you thousands. So make sure you tune in and listen up. If you're a student, we also have a week 1 worksheet from the show notes on our website and in the notes. We also have links to any references. And make sure you follow us at Medicine Uncorked and tag a friend who needs to hear this. Again, you'll find us on Spotify, iHeartRadio, Amazon, Apple Podcast, and YouTube. So until next time, cheers.